Hello everyone, welcome back to my channel. This is Dr. Thomas Abraham, and in this video we're going to talk about the FMG December 2020 medicine recall questions, and also we're going to discuss the answers. So let's begin. Question number 1. A young male with CSF findings are elevated protein, leukocytes, marked lymphocytosis, and the CSF glucose is 18 milligrams per deciliter. See, normal CSF glucose is 40 to 80 milligrams per deciliter, but in this case, this patient is having only 18 milligrams per deciliter, suggesting that the CSF glucose is low. Now here is a chart that can distinguish different kinds of meningitis. See, the biggest confusion that we must have is between the TB granulomatous TB meningitis or aseptic meningitis, which is caused by viruses, right? In both of these cases, as we saw in this patient, that this patient was having marked lymphocytosis, there is high lymphocytes. In these two cases, in granulomatous as well as aseptic meningitis, lymphocytes are elevated. But in bacterial meningitis, it is neutrophils, right? So lymphocytes are elevated in granulomatous and aseptic meningitis. But what distinguishes this both is glucose level. In viral meningitis, the glucose is normal. In granulomatous meningitis, the glucose is low. And as we saw that this patient was having CSF glucose of 18 milligrams per deciliter, that is low, suggesting it is a granulomatous meningitis. You can't compare protein because in both of them, protein may be high. So what distinguishes between them is glucose level. So the answer for this question will be tubercular meningitis, also known as granulomatous meningitis. Fine. Let's move on to the next one. Based on the ECG finding, identify. So this is the ECG finding. See, whenever you see an ECG, first thing that should come to your mind is to calculate the heart rate. Let's look how to calculate it. We take the RR interval. This is the peak of the R and this is the peak of the next R. We take this RR interval and we calculate the big boxes. See the distance between them. How many big boxes are there? 1.5. So you see 300 divided by how many number of big boxes? We have 1.5 big box. So 1.5. So the heartbeat is 150 beats per minute. This is suggesting of tachycardia. More than 100 is tachycardia, right? When do we say the ECG is ventricular tachycardia? When you have more than 3 consecutive beats of ventricular origin. See, these are of ventricular origin. QRS, 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 right? So, and the heart rate should be more than 120. Here 150. And the QRS complexes are wide and often bizarre. See, wide and bizarre QRS complexes, suggesting more towards ventricular tachycardia. Look at this ECG, 150 heart rate, wide QRS and bizarre QRS, suggesting of ventricular tachycardia. Let's move on to the next. Question number 3. This patient the patient was told to draw like this. This is the actual drawing, and the patient has drawn like this. This is the patient's copy of drawing. So let's see what this patient's condition is. See, whenever there is lesions of posterior parietal cortex, the person is unable to accurately perceive object through normal functioning sensory mechanism. He is not able to perceive with normally functioning sensory mechanism. His sensory mechanism is impaired, and this is called as agnosia. Now let's look here. This person has lost the ability to copy the left side of the drawing. The ability to copy the left side of drawing is severely impaired. This condition is called neglect syndrome. This patient will neglect everything on the left side. And what happens to this patient is there is severe damage. There is severe damage to the right posterior parietal cortex. Why? Because if the left side the drawing is impaired, if there is left side neglect syndrome, the lesion will be on the right side of the brain. So that's why there is right posterior parietal cortex injury, and this condition is called as neglect syndrome. Let's move on to the next. So the answer would be hemi-neglect. See, the hemi-neglect or neglect syndrome, both are same, and it is caused by posterior parietal cortex damage. It's not apraktognosia. Apraktognosia is inability to copy simple pictures. See, he is able to copy it, but not on the left side. So that's why it is hemi-neglect. Apraxia is inability to execute planned movement. The answer is hemi-neglect, right? Now question number 4, patient presented with complaints of discomfort on performing activities while he is normal at rest. He is normal at rest and normal activities of the patient are slightly affected, means mildly affected, right? And they have asked this patient belongs to which NYHA class. See, NYHA class is commonly used to classify the severity of heart failure. See, New York Heart Association staging system is to classify severity of heart failure. Now this patient has very slight or mild limitation of activity, right? This patient was having slight or mild limitation of normal activity, and this person was normal at rest, comfortable with rest or normal at rest. So the class of this patient will be class 2, right? Let's look into this question. So the New York Heart Association classification will be New York Heart Association class 2. Question number 5, the immediate management of the given condition is. Now look into this X-ray. This X-ray, you can see that this side, on the right side of this X-ray, you can see that this lung has completely collapsed. The lung markings are absent here, while on the left side you can see that lung markings are present. Here lung markings are absent. This lung has completely collapsed. There is a mediastinal shift to the left. Now let's look into what is this condition. This condition is known as tension pneumothorax. What is tension pneumothorax? Tension pneumothorax is a life-threatening emergency which is caused by air entering the pleural space. And what it causes total ipsilateral lung collapse. That's what we saw. And there is a mediastinal shift, and this will cause impair in venous return to the heart. And when there is impaired venous return to the heart, this patient will have decreased cardiac output. And when this patient will have decreased cardiac output, this patient will go into shock. So that's why this is life-threatening emergency. How do you manage this patient? You need immediate needle decompression. What do you need? You need immediate needle decompression and followed by tube thoracostomy. Now where do you do needle decompression in tension pneumothorax? See, a needle is inserted into the second intercostal space, mid-clavicular line. Okay, second intercostal space, mid-clavicular line, you insert the needle and you will cause the decompression, right? Decompression of the thorax. And after that you do a tube thoracostomy, all right? Chest tube insertion you will do, okay, in the fifth intercostal space, right? You do tube thoracostomy in the fifth intercostal space, right? So what would be the answer of this question? Immediate management of tension pneumothorax is, here you see left side of the chest. On the X-ray you see right side, but this is antero-posterior X-ray. So this is the left side of the patient and this is the right side of the X-ray. So here what do? You do the left-sided thoracostomy, left-sided needle decompression and left-sided thoracostomy, right? So this will be the answer, right? Let's move on to the next one. Question number 6. 27-year-old patient presented with complaints of arthralgia, that is joint pain, rough feeling of strain in the eye. Rough feeling of strain is more like a sandy feeling in the eye, and difficulty to swallow food. And the laboratory result shows anti-nuclear antibody positive, anti-Rho positive, and rheumatoid factor positive. Now, what is your likely diagnosis? Let's go to the explanation and then we come to the answer. See, anti-nuclear antibody and rheumatoid factor are non-specific antibody, means they are present in many of the autoimmune diseases. So they are non-specific. So what do we need to see in this case is we need to look for the specific antibodies. Here is a list of specific antibodies, and in this patient the anti-Rho SSA antibody was positive, and this is the specific antibody for neonatal lupus and Sjogren syndrome, and it is very much specific for Sjogren syndrome. Since this patient is having anti-Rho positivity, that's why we go for Sjogren syndrome, because anti-nuclear antibody and rheumatoid factor are non-specific. Now let's look into what is Sjogren syndrome. Sjogren syndrome is a chronic autoimmune disease which is characterized by lymphocytic infiltration of the exocrine glands, which are parotid gland as well as lacrimal gland. And when there is lymphocytic infiltration of the parotid gland, there will be what? Xerostomia. Xerostomia is also known as dry mouth. And when there will be infiltration of lacrimal gland, there will be dry eyes, which is also known as keratoconjunctivitis sicca. Now what will be the clinical presentation? This clinical presentation will be itchy eyes or sandy eyes because of reduced lacrimal production and destruction of the corneal epithelium, and this is also known as keratoconjunctivitis sicca, and there will be difficulty swallowing of food. That's what we saw in this patient. And what is the treatment? Treatment is symptomatic. You use artificial tears or you give cholinomimetic drugs like pilocarpine and cevimeline, which will increase what? Tear and saliva production. The answer would be Sjogren syndrome, right? This patient is having anti-Rho positivity, arthralgia, rough feeling of strain in the eye. This patient is having Sjogren syndrome. Sjogren syndrome is the right answer. Let's move on to the next one. Question number 7. Patient with previous history of myocardial infarction 3 years back. This patient has a previous history of myocardial infarction and now presented with tachypnea and tachycardia. And the most important thing in this question was S3. S3 is heard on the examination. What's your diagnosis? There are a lot of options here. Let's look into the explanation. S3 is more likely due to the underlying heart failure. S3 is heard in weak heart. 3, weak. See, sound similar? So whenever you see S3, you should think of weak heart, and it is likely due to an underlying heart failure. And in this patient, the history of MI is affirming the fact that this patient is having heart failure. So this patient is having history of MI and there is S3 heard. That's why the answer would be congestive heart failure. Let's move on to the next one. 70-year-old diabetic woman is on medication. Which of the following is a macrovascular complication in a diabetic patient? Now let's look into the complication of diabetic. See, I have compiled all the complication of diabetes mellitus. We have acute complication and we have chronic complication. See, acute complication are diabetic ketoacidosis and hyperosmolar non-ketotic coma, also known as HONC. And the second one is chronic complication. Chronic complication are of two types, macrovascular and microvascular. Macrovascular complication of diabetes mellitus is coronary artery disease, peripheral arterial disease, TIA and stroke. These are macrovascular, and microvascular are diabetic nephropathy, diabetic retinopathy and diabetic neuropathy. Diabetic nephropathy also known as Kimmelston-Wilson disease. And we have diabetic retinopathy, and diabetic neuropathy are of two types. One is peripheral neuropathy, which is most common. It will present as paresthesias and numbness. Then you have mononeuropathy, also known as mononeuritis multiplex, and this will produce what? Radial nerve palsy. There will be wrist drop and foot drop will be there, or any of the cranial nerves such as cranial nerve third palsy, cranial nerve fourth palsy can also be seen in diabetic neuropathy. So that was mononeuropathy. And then we have autonomic neuropathy. The manifestation of autonomic neuropathy are orthostatic hypotension, gastroparesis, bladder dysfunction, erectile dysfunction. So this is the entire picture of complication of diabetic mellitus. Now what they've asked in the question is, which of the following is a macrovascular complication? See, diabetic neuropathy, nephropathy and retinopathy are microvascular complication. So what would be the answer? It will be myocardial infarction. MI, stroke, peripheral vascular disease are all macrovascular complication of diabetes. Let's move on to the next. 12-year-old child presented with proteinuria 4+ without hematuria. Now proteinuria without hematuria is indicating towards nephrotic syndrome. And which drug would you prefer? See, let's look into the explanation. Whenever you see nephrotic syndrome in children, the first thing that should come to your mind is steroid sensitive minimal change disease. And the treatment of this kind of patient is, mild outpatient management. If there is severity in minimal change disease, then we hospitalize the patient. We start on prednisolone for 4 to 6 weeks and then we taper. So here in this case, it's a child presenting with nephrotic syndrome. What would be the answer? It would be minimal change disease. And how do you manage minimal change disease? Is by giving prednisolone for 4 to 6 weeks. Question number 10. Identify the type of murmur. This would have been very simple if you would have just known one thing. Between S1 and S2 is systole and between S2 and S1 is diastole. Let's look. See, between S1 and S2 is systole and between S2 and S1 is diastole. Fine. Now Systolic murmurs, we have different kinds of systolic murmurs and we have different kinds of diastolic murmurs. See, systolic murmurs are typically seen in aortic and pulmonary stenosis, this mitral and tricuspid regurgitation, VSD, MVP, hypertrophic cardiomyopathy, and diastolic murmurs are seen in aortic and pulmonary regurgitation and mitral and tricuspid stenosis. Now let's look into this image. This patient is having mid-systolic murmur, ejection systolic murmur. There is increased crescendo and decrescendo, matlab decreasing. Crescendo and decrescendo type of systolic murmur is there, and this is seen in aortic and pulmonary stenosis. Between S1 and S2 is systole, and here will be systolic murmur, and here you see crescendo and decrescendo, increasing and then decreasing. This is seen in aortic or pulmonary stenosis. The type of murmur is ejection systolic murmur. Let's move on to the next one. What is this condition? This condition of nails. This condition of nails is called as clubbing. This is a manifestation of central cyanosis due to respiratory diseases like COPD, and there are many others. So central cyanosis, if there, we can see clubbing, and in peripheral cyanosis we don't see clubbing. So this case is clubbing, and because cyanosis is non-specific, it can be peripheral or central, so that's why we more specifically claim it as clubbing. Fine. Question number 12. Identify this given image. Now I'm going to show you two images simultaneously. So this was the question, to identify the given image. Now look here. This is a case of Cushing syndrome. What do you see in Cushing syndrome? You see thinning of the blood vessels, and when there is thinning of the blood vessels, you see this ecchymosis and red striations on the abdomen, and you see thin extremities and central adiposity. There is redistribution of fat. There is central adiposity seen, and this is Cushing syndrome. And there is one more thing that you see in Cushing syndrome, that is osteoporosis. The vertebrae are compressed, and this is called codfish vertebra. Now here you see moon faces, there is bruisability and ecchymosis, there is this buffalo hump that you see here, or also known as fat pad, buffalo hump. This patient have thin arms and legs, and there is poor wound healing. So the condition is Cushing syndrome. Let's move to the next. What is this called? This is called as prayer sign. Where do you see prayer sign? Prayer sign is seen in diabetes mellitus. Seen in patient with diabetes mellitus. What it is called? It is called diabetic chiroarthropathy. The other names are stiff hand syndrome or limited joint mobility syndrome. This patient will be having prolonged chronic, these are chronic diabetic patient, and it occurs in 30% of them. And you see waxy thickened skin and limited joint mobility of the hands and fingers, and which eventually leads to flexion contractures. And the treatment is basically anti-inflammatory medication, pain relievers, exercise, or physical therapy, and the most important is better glucose monitoring and control. Next one, what is based on the given image, what's your diagnosis? Let's look into the explanation. This is known as Palmer xanthomatosis. See, Palmer xanthomatosis is indicative of hypercholesterolemia. We have another, we see xanthomas is seen in many states of hyperlipidemia. It's seen in hypercholesterolemia. Xanthoma is also seen in hypertriglyceridemia, but Palmer xanthomatosis like this is seen in hypercholesterolemia. And eruptive xanthoma, which is seen in hypertriglyceridemia. Eruptive xanthoma is more like reddish lesion, more of erythematous base is there, it's more like red like papules. The answer would be, this is Palmer xanthomatosis, and the answer would be hypercholesterolemia. Question number 14. Identify the number B in the given image. What is this? Now we will start on with this amazing image of pressure volume curve. See, pressure volume curve, I always start with here, with the end systolic volume. Now here is the diastolic filling, mitral valve has opened, the blood is coming into the ventricles, and because of increased pressure in the ventricle, the mitral valve will close. And once the mitral valve will close, there will be isovolumetric contraction. and after isovolumetric contraction, the pressure in the ventricle will increase more than the aorta, and what will happen? There will be aortic valve opening. So what is B here? B is aortic valve opening, and as the aortic valve opens, there will be ventricular ejection, and the blood will go from the ventricle to the aorta, and eventually the aortic pressure will increase and become more than the ventricles, and that's when the aortic valve closes. And then what happens is isovolumetric relaxation, and as soon as the pressure of the ventricle drops down than the atrium, then the mitral valve will open. So what will be the answer of this question? It will be aortic valve opening. So to identify the number B in the given image, the answer is opening of aortic valve. Treatment of the given condition. What do you see here? You see here papules, right? You see here papules, and this is in this given dermatome. This is the given dermatome, and here you see this papule, right? Here you see the papule in the given dermatome. This is the skin. In the given dermatome you see papule, and this is herpes zoster. Now there you see the dermatomal distribution of vesicles and papules, and this is herpes zoster, and the treatment is acyclovir or valacyclovir. Question number 16. Protein deposition associated with Alzheimer's disease. I don't know much of the detail of this question, but many of the students told me that the protein deposition associated with Alzheimer's disease was asked. So there are two protein deposition that we see in Alzheimer's disease, and those are senile plaques. Senile plaques are extracellular. See, these are extracellular beta amyloid core proteins. These are beta amyloid protein, and which is synthesized by cleaving amyloid precursor protein, also known as APP. So one is senile plaques, which is found by beta amyloid protein, and the other one is tau protein, or also known as neurofibrillary tangles. You see, these are neurofibrillary tangles. These are intracellular, and they are tau protein, hyperphosphorylated type tau protein. So in the exam, if they have mentioned beta amyloid protein, that would be the right answer. If that is not there, and if tau protein is there, then tau protein will be the right answer. And the degree and the number of tangles, neurofibrillary tangles, correlates with the degree of dementia. It's an important point that you must know. Let's move on to the next one. Question number 17. A patient presented with low back pain and ocular findings. Low back pain and ocular findings as anterior uveitis. This patient is having anterior uveitis, and he is HLA-B27 positive. Now this HLA-B27 positive with low back pain, there is a condition called seronegative spondyloarthropathies. Let's look into it. Seronegative spondyloarthropathies are arthritis without rheumatoid factor. That means no anti-IgG antibody. Now this is known as seronegativity without rheumatoid factor. These are rheumatoid factor negative. So these spondyloarthropathies are having strong association with HLA-B27. So whenever you hear HLA-B27 positivity, you must remember seronegative spondyloarthropathies. And there are four subtypes of seronegative spondyloarthropathies. There is this mnemonic called PAIR. P stands for psoriatic arthritis, A stands for ankylosing spondylitis, I stands for inflammatory bowel disease such as Crohn's disease or ulcerative colitis, and R stands for reactive arthritis. So students have mentioned that there was ankylosing spondylitis that was mentioned in the question. So what would be the answer of this? The answer will be ankylosing spondylitis. Now what you must remember is these pair subtypes, seronegative spondyloarthropathies, they share clinical manifestation which are similar, and these are inflammatory back pain, peripheral arthritis, enthesitis, which is inflammation of tendons, dactylitis, and uveitis. See, this patient is having back pain, uveitis, and HLA-B27 positive. So diagnosis will be ankylosing spondylitis. Now let's look into this last question. What is the diagnosis of this given condition? There was an X-ray, and here is jugular venous pressure curve is given. Now here on the X-ray, what do you see? You see here calcification of the walls of the pericardium there is significant calcification. You see down here there is significant calcification is seen. Now let's look into the description. See, this kind of calcification is probably seen in constrictive pericarditis, but you can also think that this is looking like a money bag appearance which is seen in cardiac tamponade. So the main differentiation comes here is in the first three. We confuse in the first three. Now let's look into the description. Let's begin with constrictive pericarditis. In constrictive pericarditis there is diffuse thickening of the pericardium, and this pericardium thickening is due to inflammation. Now what is the etiology of constrictive pericarditis? In most of the cases, in majority of the cases, the cause is unknown, or sometime it can be viral in origin. After viral infection the patient may have constrictive pericarditis. Now what happens after this inflammation is there will be reduced distensibility of the cardiac chambers, and when there is reduced distensibility or reduced compliance, the patient will have low cardiac output and there will be abnormal diastolic filling, and this patient will go into finally shock. And what do you see on X-ray? We see thickened pericardium and we see pericardial calcification, and that's what I saw. But the most important finding that they mentioned here was on cardiac catheterization there is marked Y descent present in right atrial pressure tracing. See, now let's look into it, right? Marked Y descent present in right atrial pressure tracing. See here, there is marked Y descent. This marked Y descent is seen only in constrictive pericarditis and it is not seen in cardiac tamponade. So let's look here. Here is the cardiac tamponade. You don't see any Y descent, but in constrictive pericarditis you see there is significant Y descent, and that's why the answer of this question will be constrictive pericarditis. And what is the treatment of constrictive pericarditis? It is conservative, mild sodium restriction and diuretics, and if the patient is having severe problems, then we go for pericardiectomy. Now what is the diagnosis? There is severe Y descent, there is pericardial calcification seen here, so the answer is constrictive pericarditis. Thank you for watching and don't forget to subscribe. And I must say that there were so many questions of medicine from our Telegram group where we posted important concepts related with general medicine. So if you haven't joined our Telegram group yet, don't forget to join, and also please subscribe to our channel. See you next time. Bye bye.